was regarding pricing or payment for, an innovative device, the Argus II the Argus II retinal prosthesis. Very expensive, very uncertain what its future really is in terms of the whole population, probably small. But the pricing structure that CMS applied made no sense. It, in fact, can't work. And so they set up a situation where that technology is currently, I think, in limbo unless other things change. And so we'll see a lot of work there. So, Bill?
I think the biggest factor is the biggest issue beyond MIPS, MACRA, is the tremendous uncertainty that's permeating health policy in the United States today. No one knows where we're going to be. No one knows how we're going to get there with the current proposals. It's incredibly complex. And we should kind of ask ourselves what we're asking ourselves now. How could a bill be so great when you can have unanimity of opinion between Democrats and Republicans on one piece of legislation? And we're starting to find out that it is grievously flawed. So Michael's talking about the uncertainty, but there's global uncertainty from the part of payers, on the part of patients, and physicians. And we're part of that uncertainty. There's the dream that physicians will be popular. There'll be no more fee-for-service. The reality is that every single delivery system in the world that we lust after uses some form of fee-for-service. The Dutch, etc. So there's kind of a disconnect between some of the policy agenda that Michael was talking about, the merit-based incentive payment systems, etc. These are really top-down designs by policymakers sitting in a room that really had no idea of what 16% of the GDP is doing. So I think it's more the uncertainty, the unreality of some of the proposals. Our job is to find a glide path to help our patients and our members get through this time of great uncertainty. We've seen many things come and go, and when something is this complex and it's this big an issue for the American people and for the economy, I'm not sure what we're going to end up with. I don't expect anything dramatic to be accomplished. We're gearing up to an election year, so there'll be a lot of spin about the merits of the law that was passed. But we're really going to know the reality after the change in administration, whether it's a deer or not. They're going to bring in their own policy people, and they're going to face the reality of what is the final face of this change system is going to be. So the biggest thing is just the uncertainty of how healthcare is going to be delivered and how the role that technology and physicians are going to play in that uncertainty. But Michael and I have been reading federal rules for a long time. We're kind of geeks. I'm getting too old and print's too small for me. But there is, when I have to read a federal rule 3 or 4 times, there's something wrong with the entire design process. And a rule comes out, and Mike and I will look at one another and say, what? And
did they really mean that?
Yeah. So I think the biggest thing is uncertainty. Uncertainty, it makes it very difficult to plan and to strategize for the future. But we've always succeeded in the past. We've got a great team of analysts and staffers that Mike oversees, and I'm more on the quality and the registry side. I'm still optimistic, but we will face a lot of challenges. So it's hard to give you, really glide points and a path of what we're going to do, because frankly, federal policy doesn't know what they're going to do.
But suffice it to say, we're going to have some programs designed either by us or by CMS, frankly, that at least give specialists a avenue to participate in some of these programs.
I think we're in a better position than any other specialty to meet these arcane and incredibly complex demands of the merit-based and payment, I can't even say it anymore,
System.
MIPS, and alternative payment models. We are in the design phase of putting together proposals that we think will meet the regulatory needs, how efficacious it's going to be. The rules haven't even been written for the major restructuring of our healthcare system. It's supposed to be implemented in 2017. There's no rules yet, so chaos reigns. Questions?
Why don't we open up to questions?
Sure.
Hey,
Scott here.
oh,
And could you introduce yourself and tell us your outlet?
hi, I'm Scott Kraswanis. I'm with Retina Today, New Retina MD. A question about MIPS. Are there any specific, how do I phrase this? Are there any specific portions that you'd like to see included after this MIPS system finally gets finalized? I mean, are there something like I think about, let's say, the high cost of drugs that might affect a specialist's, a retina specialist, say, their MIPS score. Is there anything that the AAO is going to do to try to work this out?
Well, one presumes we're going to, like every retina specialist and our association is going to say, you know what, Part B drugs should not be a factor in that. Now, today they are a factor in some of the quality resource utilization reporting. So we will argue that. I don't know that we'll win that argument. In fact, I would argue we'll lose that argument.
I agree with Mike. And the one thing that's in our favor is, since 1985, we were one of the first 3 specialists to put together evidence-based quality guidelines. So that's part of our culture, is quality improvement. And the weighting of this MIPS, and there's 4 things: there's quality, resource use or cost, practice improvement, and meaningful use. And the weight is going to be 50% initially for quality. And so we have positioned the retinal community and all specialists with outcome measures that we assume are going to be part of MIPS. And with the use of the registry, we feel that we're better positioned than any other specialty to meet the quality reporting requirements. And we're doing it not to meet the requirements, but to improve quality. So it's kind of nice that you can get a twofer. So we do feel that we're positioned. And one thing that is really unclear is the methodology for assigning costs. But the drugs will be in there. You know, there's many things being bandied around, and one of them is kind of a grouper, right, Mike? Never been tested. Never been tested. Every other way of assigning costs and allocating it to a position, they've looked at statistical R-squared numbers to see how statistically valid they are. This hasn't been done with any of the allocation things for costs. That's why they're weighted so low initially. So the retinal community get a break up close. But using the registry, you know, we had this up and running for a different reason, and now we're finding out this is of immense value for the across all of our subspecialties, because quality, as we do measure quality. There are ways we can measure resource use, practice improvement, and by definition, you're using a EHR. So the members that are on an EHR will be able to actually do quite well with the arcane MIPS system, even though we haven't seen the rules yet, but I'm betting.
Right, but I guess it's fair to say that one of our challenges is to influence regulations that allows or makes it feasible for the registry to do this program. So that will be one of our continuing efforts. And I'd say it's true throughout all of the legislative activity and regulatory activity, is to make sure that data registries are part of future or new programs.
The law actually states the secretary shall encourage the use of clinical data registries. That insertion of the bill came from the Academy, frankly, with the support of other societies, but it was the advocacy with Mike's team that got it in there. It's nice to see it word for word when you see something in the law.
I guess, Bill, one thing we didn't make clear is that no matter who is in the White House for the beginning of 2017, it doesn't change this program. I mean, anything they do is years down the road. So I think this program happens.
And I don't think we're going to see much until 2017, which means 2018, because again, we haven't seen a rule yet. These are incredibly complex rules it's got to come out next year. How are you going to implement that in between November of 16 and January 1st of 17? So that's why I think you're going to see a lot of stasis, a lot of spin. We're doing this, we're saving Medicare, but nothing's really going to happen much, I would guess, until 2018.
Now, we are writing comments on MIPS, which of course all interested stakeholders are doing at the moment, and those will be submitted well, in a few months. But this is the part of the pre-rule writing process. So the rule will come out and then we'll comment again. But I think the timeline's going to get so tight later on.
And CMS, they're the ones charged with implementing, writing the regs and everything. They have some really smart, hard-working people. But frankly, they don't have the bandwidth. They're working their tails off, and I don't know how they're going to do it. But they're working way beyond the 40-hour a week to try to get this stuff done. But it is so complex, and I'm just concerned that the implementation is not going to come out on schedule. It will be a year later for both political reasons and practical reasons. I don't think they're going to get it done in a reasonable way.
Next question.
So no one's asked you about the fee schedule?
Oh, yeah, I was going to ask.
Okay.
I'm actually still more. Hi, Scott again. I still have a question about MIPS. You mentioned that there were some comments that you were going to make on the.
So we're developing comments. It's a collaborative process from staff and doctors, other medical groups. AMA is certainly helping look at it from their perspective. The American College of Surgeons similarly, and so where their comments are helpful, we will almost certainly adopt them. Because this is a huge process to write.
Are you willing to talk about any specifics as to what those comments might be, or is it too early?
It's too early.
Okay.
Yeah.
Other than to say the registry functions need to be maintained in each of the categories. I mean, we want that to cover each of the areas so that the registry can work for all of them.
Do you want to ask about fee schedule?
Can you tell me about the fee schedule?
Well, I don't know. What have you heard?
Not much, to be perfectly honest with you.
And you write for Retina Today.
Yeah, that's right. It's a bad news organization.
Well, no, that must mean retinologists don't care. No, we know that's not true. No, the 2016 fee schedule has some very bad cuts, very deep cuts for some of our procedures in retina and in the glaucoma space. So these are the biggest we've ever seen at least we've ever seen recently. The good news is that our staff reminded me, and I'm sure they reminded Bill, that, gee, we put into legislation last year in MACRA that it could only cut us by 20% 1 year, so if the cut was bigger, it didn't go down all the way. You've got to phase it in over 2 years. But we have procedures in retina that are over 20% in cumulative cuts in big procedures, retinal detachment repair, one of the codes they do most often.
And the sentinel codes for glaucoma are cut over 30%. The problem is that we've used the resource-based relative value scale since it's passed in '89, implemented in '92, I think. And it's actually the basis of reimbursement within groups. Insurance plans use RBRBS, and with the current administration and MACRA, they're arbitrarily not looking at resource use, the intensity, how hard it is, medical effort, judgment, technical skill to perform it. That was the basis of RBRBS. And ophthalmology has always done well because of the technical difficulty, the high risk to the eye, and that's been thrown out the window strictly to meet mandatory budget savings. They had to come up with $1 billion in cuts in Medicare, in the first 3 years, in quote, misvalued codes, with no hint that they were misvalued, so a lot of these are arbitrary cuts, so that's what's, before if it was a failed process and your peers said, you know what, this is overvalued for these 5 reasons compared to what everyone else does. And that's kind of not what's happening anymore. They're just arbitrary cuts. So a lot of physicians are losing their faith in the entire Medicare fee schedule. And this is actually one of the ghoulish side effects of the SGR fix bill. I better be quiet on that.
But if I could just amplify, so ophthalmology surgical procedures, typically you sit down, the procedure is like you're ready to go, you're doing the whole thing. Whereas some other surgical procedures that had skin, doing an abdominal procedure, you didn't get quite the intensity for that period of time, and for opening and time for closing. And so that you could always make sense that ophthalmology procedures were more intense per unit time. But if you use time alone, you're much better off spending an hour or two opening or closing an incision than frankly doing the procedure itself. So the other thing I wanted to add about time is time is still a bona fide measure. It's not as if the time values CMS came up with were wrong. The Academy and each of the involved subspecialty societies participated in the survey process. They developed, and the members who did it in a volunteer basis, they filled out the surveys, did reasonable things. There was nothing crazy about the times they reported. It wasn't that I can do a 6-minute procedure. It's just that between 1989 or 92, some of the procedures have gotten faster. A lot of surgery has gotten faster. Better instruments, better techniques have made glaucoma surgery faster, have made retinal surgery faster. So time is still a factor. There was nothing wrong with the times. We are faster.
The big problem is that within RV or RVS, there was a design and the assumption that procedures were overvalued. And all major procedures have gone down. If you look across the board, on average, 52% since 1995. And the poor retina guys and the glaucoma guys, it just caught up with them. That doesn't mean they were accepting it, because some of the cuts recommended above the ruck were ridiculous. There was no rationale. And those will be appealed in what's called a refinement process. But the whole construct that interventions are overpaid is really, the data is striking. 52% in $95, not inflated dollars. As a specialty, we've done remarkably well, but that does not dissipate the pain of the glaucoma docs doing incredibly complex procedures nobody wants to do to save an eye. And the retina guys doing a buckle on a high myope or traumatized eye. But the reality is, if you look at the profession as a whole, we're the only surgical specialty that hasn't had an overall cut. Was it 7 to 10 years, Mike? Something like that.
Yeah, we're well, the data that we've looked at.
Exactly right. And cardiology's down about 27%, radiology over 70%. So overall, we're still doing quite well, but the problem is that it does not dissipate the pain of those people taking care of really sick patients, and we're not happy with it.
You touched on that real briefly, and I was wondering if you could expand on that, the role of the RUC right now, given the relationship with CMS and this most recent fee schedule.
I spent 16 years of my life at the RUC, chaired it for 6 years. And it really was a deliberative body. And people laboriously, painfully would do the right thing. We'd meet 3 times a year, 5 days, 8 to 10 hours a day. And in the end, you go out and have a beer, sometimes more than a couple, after you fought and debated one another. So it's a process that worked. I'm not sure that it's worth the effort if someone's just going to say, I'm going to put a stopwatch on you and we're going to cut you. That's not what, that doesn't take into effect the iatrogenic risk, technical skill. It doesn't take into any of the constructs that actually are defining the value of the service. So a lot of people are expressing some concern about the future of the RUC. They're just going to, when I was chairman, the average acceptance rate of the values was 94% by CMS. Now it's around 50%. So they're very arbitrary decisions. There's no rationale for the cuts. They're comparing a code with 40, 50,000 a year usage to a code that had seven procedures done. There's not statistically valid. That's what CMS is doing. So that's a good point. I'm not sure what the future of the RUC is. And there's a lot of people around the world that use RVS for their payment systems. and they're used within, again, medical centers to look at productivity. So they're kind of destabilizing the whole system.
But at least for the moment, we will continue to participate, and I'm sure this is a big issue for the AMA to cope with, because this is one of their
Body. CMS has sole authority to accept, reject, or modify those recommendations. So we don't set fees, we don't set values. Yes, sir.
Howard Larkin, Eurotimes. What would you consider to be an appropriate way to bring outcomes into the payment mix?
Actually, they have,
Assuming you could leave intact the structure of the current input structure that it's based on.
that's a great question, and we've anticipated that. As you know, most quality measures now are process measures. Did you look at an eye and correctly stage the level of stage of diabetic retinopathy, macular degeneration? And process measures are very powerful because it makes you evaluate, note, and then actually make a decision on diagnostic or observation or interventions. However, the need is for outcome measures. And if you read the law, and even before the law was written, there is a move to accept no more process measures. We have to have real outcomes measures. Anticipating this, the Academy 3 years ago, in the IRIS registry group and measure development group that I chaired, really developed, I think it's actually 18 or 19 outcome measures, rock solid outcome measures based upon a strong evidence base. For a new case of wet AMD, what is your logMAR change in vision over X period of time? And those can be made publicly available, if you like, through the communication staff. But we have them that actually cover all the high-impact interventions, diseases, including pediatrics, even though they're not part of MIPS or anything like that. But we do have, again, the registry was formed for quality improvement purposes, and so we're ready to roll with the outcome measures. So it's also happens to coincide with the focus of the weighting of MIPS 50% to quality, and we know they're going to have demand for outcome measures. They will be risk adjusted, and they will be publicly reported. You'll have to probably, we don't know, I shouldn't say because the regs haven't been established, but we anticipate there will be that you will look at your outcomes, have to pick 2 and publicly report them. I'm not sure anyone reads those reports from CMS, but journalists do. So.
Right, and so that's a good reason to have them. But the other thing, if I could say, I think the Academy is very interested in promoting outcomes work, and we certainly don't want to ever give the impression that we're not interested in that, because I think that is how you move medicine forward, and I certainly think that's the Academy's position. I will comment on those measures. I think the ones that Bill's work group, or the work group that was working for the IRIS, made measures that were pretty tough. And certainly we've had a lot of pushback from people saying, gee, that is aspirational. That may not be realistic.
Problem is that the doctors want to get a 100% score.
That is
They
true.
want to hit 450, have a 1.1 ERA, and that's not the way it is. If you have a large number, you're going to have some variation in your results. And if you have a 100% success rate in amblyopia, you're cheating. You're going to get audited. And so a lot of the physicians are saying, oh my goodness, but not all my patients are going to achieve that goal. But there's going to be a huge database. The IRIS is the largest database in a registry in the world already. So you're going to have a rock solid benchmark to compare yourself to that's very diverse. And if you have low numbers for an outcome measure, you're not going to probably report that. But if you have good numbers, you will report it. They are tough measures, but they're, you know what, that's how we advance science.
We created them ourselves.
We created them ourselves, that's correct.
Another question.
It's gonna be your new
Thanks. Hi, yes, filled with questions.
Thank you.
If we could shift topics for a moment. In September, the OIG came out with that report on questionable billing practices for certain ophthalmic codes. I can only speak from the retina side. Some retina doctors were absolutely furious at the scrutiny. Others looked at it and said, this is actually great news. It turns out that a lot of us are following the rules. Does the AAO have a position on this?
So I would say our position is exactly like the second set of doctors. Didn't we do a great job? Yes, there were a few outliers, but overwhelmingly, that had a pretty low error rate. But again, it did identify a couple outliers, and you can look at their cities in that report and probably have a pretty good idea of who they were. No, I think that that's always good to look at the data because that can lead to some improvement, but I would spin it very much as a positive.
I'd like to go back to the gentleman from Euro Times. So we do have a couple of outcome measures we've already collected. For instance, cataract, returning the OR within 30 days. And so we were interested in what our European colleagues, and we went back to the Swedish registry, we had about 363,000 cataracts. We looked at it at 486, we're over 1 million now. And we're within a percentage point or two of our European colleagues, which is very reassuring because ours is extracted from EHRs. Theirs was a very laborious, expensive data inputting by nurses in the facilities. So it's a nice validation that our first outcome measures are lining up with our European colleagues. And we do communicate with our European colleagues in registries, Malaysia, Arabic in India, New South Wales, and our European colleagues.
So is that something that's being used at this point?
Oh yeah, yeah. So we have a really extensive database on the number of times there's a major complication returned to the OR. We have some really great data that shows significant complications, safety errors, wrong lens, had to go back and exchange it. We already have robust results for the first 15 months.
So, but this isn't in part of the reimbursement system?
No. Well, actually it is. So, the doctors can report on that as one of the outcome measures.
So those could be something.
Yes, yes.
There's a question over here.
Yeah, I'm Kristen Antonito from MarketScope. Back to the drug discussion, what do you see as far as rules and legislation coming up as far as compounding pharmacies are concerned? And what role do you think that's going to play coming forward?
So like the media, we're anxiously anticipating FDA issuing final guidance on compounding, particularly with respect to the outsourcing facilities or the 403B companies. We don't know what they're going to say. We commented extensively in April of this year on it. We recognized that the BUD, or the Bayou State, that was in the draft guidance is essentially untenable or unworkable as a solution. We're looking at, my glasses on to see.
Second page.
Thank you. We're looking at legislative help on this. We're certainly looking for friends. We had a letter sent to, that's actually not the bill I was looking for. We had a letter that we helped get through the Congress. We had a number of senators and congressmen on a letter to the agency asking them to be careful and to understand what they were doing. And so I'd say we wait for it. It could certainly change the retinal marketplace significantly depending upon what the agency says.
This is a great example of the chaos that exists in Washington now. What is the gold standard of comparative effectiveness research? It's the CAT trial, the Academy, National Eye Institute, and HHS designed to show equal efficacy and risk of Avastin versus Lucentis. And now there's the chance we're going to have significant problems of access to Avastin, especially for rare cases. That's the only treatment now that there's coverage for. And if you look at our emphasis on costs, all the accountable care organizations, after 3 years, have accounted for, you've seen these reports in the press, savings of $412 million. That is about 6 weeks out of a year of the use of Avastin That's about the 6-week savings of the use of Avastin. Avastin saves, and the use of it, the judicious and appropriate decision to use Avastin by the retina community at their financial disadvantage saved Medicare $4 billion a year. So you have a piece of legislation and regulation which actually might wipe out one of the biggest cost savings within Medicare. That's an example of the chaos.
Or at least lack of coordination.
Chaos is a better word.
Thank you.
Any other questions? Well, if there's nothing else, I appreciate you guys coming. We're happy to follow up with you in any way, and have a nice afternoon.
Thank you as well.
Thank you.